So we think, as we just mentioned about the pathological complete response rate in the nab-paclitaxel usually trial, that we have a higher pathological complete response rate. So usually, if there is a nab-paclitaxel, yes, it's better to combine with nab-paclitaxel rather than the paclitaxel.
Okay. I guess for the expense of the time, I'd like to ask Professor Khaled Aziz, who is online, to share with us a real-life case scenario about the triple-negative breast cancer. Dr. Khaled, the floor is yours.
Good morning, dear professors. I deeply apologize for not being able to be there for just a medical cause. I'll try to be rapid and consolidate on the data that have been presented. So this is a triple negative breast cancer case in an early setting. She is a very fit 67 years old lady with no comorbidities, which is taking very well care of her life and habits and nutrition. She has no family history of oncological diseases. She presented 7 months ago with a right breast lump, and a sonography was done revealing a right breast lesion in the upper outer quadrant, 3 by 2 centimeters, with no suspicious axillary lymph nodes. The biopsy at this time revealed invasive duct carcinoma grade 3. And the discussion we had, because before having the biopsy, I told her most probably at her age, without having a family history, most probably it's going to be a luminal A. Most probably you're going to go for surgery at the beginning, then maybe a chemo-free adjuvant treatment. And then with a grade 3 invasive duct carcinoma, we discussed the possibility to perform first immunohistochemistry or to proceed to surgery upfront. So I would like to hear your opinion on this first question.
Professor Ala, would you like to kick off the question? He is asking, because this is a T2, it's an early breast cancer. I don't know about the breast tumor volume, but actually this has come with the MDT when we discussed, this is a 67 years old lady, where we expect that she will actually more or less have a favorable pathology. However, there is a grade 3. So some surgeons would urge that to go directly for doing the surgery. However, Khaled is asking if you would like to urge and to wait to listen for to have the immunohistochemistry, the ER, PR, HER2, and the Ki67.
Dr. Khaled.
Yes,
this is a very good actually point you're raising. Actually, I mean, you don't manage any breast cancer patients until you do the immunohistochemistry and determine what type of breast cancer you have. So no matter what age of the patient and tumor bulk, you have to have a true cut biopsy, do the ER, PR, HER2, Ki67, and then you discuss that in the MDT. You have to do that.
Definitely, totally agree. So the patient had an immunohistochemistry revealing a triple negative breast cancer with a Ki67 of 35%.
Khaled, Professor Mohammed Yassin would like to commend Khaled.
Yes, please.
No. I have the same opinion like Professor, and you don't do anything until the results of the ER, PR, HER2, and Ki67. So I do agree again. Yes.
Please continue, Khaled.
Totally agree. So immunohistochemistry had a triple negative breast cancer, Ki67 35%. A clip was placed and for further localization. And she received 4 cycles of adriamycin and cyclophosphamide with complete response by clinical examination and radiological evaluation. The patient is very slim. She has a small breast, so it was easily seen by examination. And radiologically also by sonography, we couldn't localize the lesion anymore, just the scar at the site of the clip. So the question number 2, would you proceed with surgery or continue a full course of chemotherapy? So this is a straightforward question. And I will add the third question with it so we can reply. If we are going to continue, would you continue with 12 weeks of paclitaxel or not paclitaxel? or AC, docetaxel, or TAC, or you would prefer to start with a TAC regimen from the start?
Professor Hisham,
So it is like it's a combination question. So I think first it is important to assess the triple negative disease by MRI rather than the mammography to have a better assessment of the radiological complete response. And I really go for MRI in patients with triple negative breast cancer, and I think this patient surely going for insertion of CLEP before starting treatment. So it's very good to have this good outcome, and according to our recommendation and consensus last year, that it's better to continue the full course of chemotherapy before going for the surgery, because there is some discordance between the radiological complete response and the pathological complete response. So it's better to be sure that you have the full treatment before going to surgery.
But would you like to add the platinum agent with it?
Yes, I am usually with the platinum in the neoadjuvant setting.
Okay, great. So a further exploratory question in this case, should the patient be tested for BRCA mutation or HRR defective pathway at this moment for decision of treatment? I do not mean for academic reasons.
In my opinion, in this patient with 67 years old, I'm inspired that usually we go for assessment of the BRCA in the triple negative population, but there is no need now to go, not affecting our decision at this moment. So we can go later, but now it's not affecting our decision. Maybe important for research purpose, but it is not for the clinical decision.
Great. So, and to join it with the question number 5, it wouldn't affect our decision to add a platinum agent if there is a BRCA mutation or an HRR deficiency, right?
so Professor Ala, would you...
What's the question? I'm sorry.
Khaled is asking about that, as Professor Hisham had highlighted, that there is no rush to go for the BRCA assessment, despite that the patient is a triple negative, but being 67 years old, that would not make us in a rush to do the testing. So actually, Khaled is insisting on the question about should the platinum agent be added or not, despite you are unaware of the BRCA status in the triple negative. Maybe not in this particular case itself, but in general.
Okay. Actually, can I just comment also on the same line as Professor Hisham mentioned, which I totally agree with him, that patients who achieve good clinical response should continue chemotherapy as long as they are having good clinical response. But do not depend on clinical response in the neoadjuvant setting, because the correlation between clinical response and pathological response is not better than 50% in the best hands. So many patients, you think they are complete clinical responders, have residual disease, and vice versa. And you should not be pushed by your surgeon colleague that this is now a very small tumor amenable for surgery, but no, because you're not aiming at triple negative at downstaging only, you're aiming at complete pathological response. And as long as the patient is responding, and there's no difference between neoadjuvant and adjuvant in terms of disease-free survival and overall survival, if not better with neoadjuvant, so you're better off completing the full course of chemotherapy before surgery and then go. I will add platinum. I'm a fond of platinum in triple negative patients with paclitaxel. Unfortunately, we don't have nab-paclitaxel, but I will do that. With the BRCA testing, I don't see the urgency for doing it right now for this patient, apart from academic interest, but right now for the taking treatment decision for these patients, I don't see a rush in doing that right now.
So that's clear, but maybe I play a devil advocate here because we don't have surgeon in the room, I guess, but they will say that we are... Yeah, okay, sorry sir, that it's my side that the light is not... So actually, that's what we hear as well in the MDTs, that now we are in the COVID era. chemotherapy is subjecting patients to more immunosuppression that may be having more interruption if they got being infected with COVID-19.
But actually that will not make a difference because surgery will go in a couple of days and then the patient will go to chemotherapy 2 weeks after and we are still in the COVID era. So
nothing will be changed.
That's the point that I would like to highlight to some of the surgeons who are actually pushing on the surgery because of the COVID, and that's what they tell patients.
Okay.
Rida, I want to comment?
Sorry?
No, we are not pushing the patient. The patient should continue the full course of neoadjuvant, and then we start our job.
Perfect.
Okay. We hope that all surgeons would be in the same wisdom like you, sir.
Yes.
Khaled.
So, Khaled, can you please continue?
Yes, sure. So the last slide, the patient continued on 12 weeks of paclitaxel. We didn't add carboplatin, but luckily enough, she underwent a breast conservative surgery and she had a complete pathological response. Therefore, only post-operative radiotherapy was recommended, then follow-up. Thank you very much.
What about maintenance? What about the issue of maintenance we have discussed right now? What to do after complete pathological response? Should we offer maintenance or not, according to Professor Marwan and Professor Ala?
I mean, this is a personal view. I don't add adjuvant treatment to patients who achieve complete pathological response.
Yes.
But I definitely do add when they do not achieve complete pathological
Perfect, okay. To have a consensus today, yes.
Yeah.
I just mentioned, you just mentioned in your presentation, sir, about that we can go for like molecular subtyping to know if there is any need for capecitabine according to the molecular subtypes of the triple-negative breast cancer. So do you recommend to go for this? And if we don't have this molecular subtyping here, do you recommend to go for the for like maintenance treatment? Better to miss the opportunity of the patient to be cured.
This is an excellent point. Actually, if we have the facility to do this subtyping and know if this patient is basal versus non-basal, yes, you might argue that you can give, because actually in the non-basal there was a real benefit in terms of disease-free survival and overall survival. However, this is only one trial, but I'm really interested in seeing what is carboplatin showing us in the same setting and immunotherapy. Again, I'm looking forward to see the data.
Thank you so much. Thank you, Khaled, and we really miss you being here. We shall continue the presentation, and we should have Professor Nagi Saghir is still